Welcome to the Explainer. Today, we're diving into one of the most common things you'll see at the pharmacy counter, acute diffuse otitis externa. You know, swimmer's ear. Think of this as your practical, go-to guide for assessing, treating, and counseling your patients with total confidence.
So, here's our game plan. We're going to follow the exact flow of a real pharmacy consultation. First, we'll get a handle on the complaint itself. Then we'll cover assessment and that crucial triage moment. After that, we'll talk about picking the right product, and we'll wrap up with how to counsel for real success. All right, first up, let's get on the same page about what acute diffuse otitis externa really is, and more importantly, what it looks like when a patient walks up to your counter asking for help. So when a patient comes to you complaining about their ear, this chart pretty much tells you what you're going to hear. The number one reason they're there? It's almost always pain. Otalgia. We're talking 70% of cases. Yeah, itching is a close second, but that intense, nagging pain is your first huge clue.
So what are we really dealing with here from a clinical standpoint? Well, it's an inflammation of that outer ear canal. The key thing to remember is how fast it comes on, usually hitting within just 48 hours. And the bad guys here are typically bacteria, like Pseudomonas or Staph aureus, which just love that warm, moist environment.
Okay, so a patient shows up with these symptoms. Now our hat changes, right? We go into assessment mode. It's really all about asking the right questions to nail down what's going on and to figure out how bad it really is.
And here is a fantastic diagnostic clue you can use, right there at the counter. Just ask the patient, does it hurt more if you gently pull on your earlobe, or what happens if you press on that little flap of cartilage right in front of the ear canal? If that movement makes the pain worse, boom, your suspicion for acute diffuse otitis externa should go way up. It's a classic telltale sign. Think of this table as your triage roadmap. If you've confirmed that pain on motion, great, you can probably assess for self-treatment. But take a look at the other possibilities. See a localized boil? That might need a referral if it looks bad. An itch that just won't quit? That screams chronic or eczematous, and they need a doctor to figure out the underlying cause. And then there's the one at the bottom, necrotizing OE. That is an absolute lights and sirens medical emergency. And that brings us to what is probably the most critical decision you'll make in this entire consultation. This is all about spotting those red flags, the signs that tell you this patient needs a doctor right now, not just a bottle of drops from your shelf. So, this is the million-dollar question, isn't it? What are those specific warning signs? What's the dividing line between a standard case of swimmer's ear and this really rare but incredibly serious complication? Okay, these are the non-negotiables. These are the signs that mean you stop what you're doing and make an immediate referral. Listen for complaints of severe, deep pain, not just surface level. Ask about any foul-smelling discharge, any mention of fever or facial weakness. And definitely, if the patient is diabetic or immunocompromised, your antenna should be way, way up. Any single one of these means it's out of our hands.
Whew. Okay, so we've done our due diligence. We've ruled out the red flags, and we're feeling confident that this is an uncomplicated case of acute diffuse OE. Now we can switch gears to treatment and figure out which topical therapy is the best fit. So you've basically got two main camps to choose from. For those really early, mild cases, symptoms that have been around for less than a week, a simple acidifying agent like acetic acid can work wonders. It just helps restore the ear's natural, healthy pH. But if the infections had more time to set up shop, say longer than a week, that's when you want to reach for a combination antibiotic/corticosteroid drop. That'll tackle both the bacteria and the inflammation. Now, if you do go the antibiotic route, this choice is absolutely critical. Aminoglycosides, they carry a risk of ototoxicity, of hearing damage, and that risk skyrockets if the eardrum happens to be perforated. Here's the thing. We can't look in their ear to check the eardrum at the counter. That's why fluoroquinones are by far the safer choice. They are not associated with ototoxicity, which makes them the go-to class when we're treating this from the pharmacy. And let's be perfectly 100% clear on this next point. This is a local infection, and it needs a local treatment. This quote from the clinical guidelines says it all. For uncomplicated cases, giving oral antibiotics does not help. All it does is increase the risk of side effects and, you guessed it, antibiotic resistance. So please stick with the drops. All right, last but certainly not least, let's talk about our vital role as counselors. I mean, recommending the right product is only half the job, right? Making sure the patient actually uses it correctly and knows how to stop it from coming back, that is where we really make a difference. Proper technique is everything. If they do this wrong, the treatment could fail. So let's review the key steps to teach. First, tell them to warm the bottle in their hands for a minute. Cold drops can make you dizzy. Second, they have to lie down. This isn't optional. For an adult, pull the ear up and back, fill the canal with the drops, and then, this is the most important part, tell them to stay lying down for at least 3 to 5 minutes. That gives the medicine time to get all the way down where it needs to go. And for prevention, you can give them 3 simple, memorable tips. 1, keep the ears dry. After swimming or showering, use a blow dryer on the low cool setting. It works like a charm. 2, absolutely nothing in the ear canal. No cotton swabs, no keys, no fingernails. That just causes tiny scratches where bacteria can grow. And 3, if they wear hearing aids or use earbuds a lot, they need to take them out at night and clean them often. And here's the timeline you give them for follow-up. You need to counsel your patient that they should feel a lot better within 48 to 72 hours. If they're not seeing significant improvement by then, or if things are getting worse, that's their cue to go see a doctor. So I'll leave you with a final thought to chew on. With antibiotic resistance becoming a bigger and bigger problem every single day, we have to ask ourselves, should non-antibiotic options like simple acetic acid start playing a bigger role? Should we be reaching for them first in those early, mild cases? It's something we all need to think about as we practice good antibiotic stewardship.